Good morning, ladies and gentlemen. Welcome to the APHRS Interventional EP Curriculum, the VT module webinar series. Today, the topic is the step-by-step approach to do the Outflow-Tract ventricular tachycardia. I'm Dr. Lin Yan Zhang from Taipei Vision General Hospital. So it's my honor to chair the section. And first of all, I'd like to introduce our faculty today. The first speaker of today is Professor Luo Liwei. The Professor Luo Liwei is a professor of National Yang-Ming University and also the director of the Heart Research Center of Taipei Vision General Hospital. And today we are also honored to invite Professor Jim Chong. Professor Chong is a Weill Cornell University and a Medical Center from New York, USA. So welcome to the section. So first of all, we'd like to invite Professor Luo for to give the presentation. Dr. Luo.
Okay, thank you, Professor Lin. And okay, I would like to share my screen. Okay. Okay, can you see my screen?
Okay, thank you.
Okay, thank you. Good morning, everyone. Here I would like to talk. Today I would like to talk two cases of the Outflow-Tract ventricular tachycardia and how we identify from EKG and what the procedure what we will do during the procedure and about the ablation detail for these two cases. Okay. Going to the first case, this is a clinical history of the first case. She is a 20-year-old girl and suffered from palpitation for several years and got worse in recent 3 months. And Holter monitoring from outside hospital last month showing a sinus rhythm with a BPC burden of 15%. And the echocardiography was normal chamber size and normal left ventricular ejection fraction. And this slide shows you the baseline 12-lead EKG, and you can see obvious lots of BPC in this surface EKG. And the BPC morphology is in the precordial lead is left bundle branch morphology with a transition around V3, V4 to V5. And also there is an inferior axis, lead 2, 3 ABF are all positive. So it indicates it could coming from the Outflow-Tract region. So when we look at this EKG, we will think that it is coming from the left side or right side Outflow-Tract. And there are several algorithms help us to identify that. Of course, you can use the V2 transition ratio, and I will show that later in the slide. And also you can use the transitional zone index. And you can see that during the sinus rhythm, the transition is at V2 to V3. And during VPC, the transition is around V3 to V4. So that is later to sinus rhythm. So if the sinus rhythm transition is earlier and VPC transition is later compared to sinus rhythm, we will have a positive transition score. So if that is positive, that means it is highly possible to be coming from the right side RVOT. And if that is negative, then you may need to search the left side. Another is the V2 transition ratio. And for the first step of the V2 transition ratio, you also need to see the transition area of the BBC. If that is early around V2 to V3, then we will use the formula to count the transition ratio. So this slide shows you the concept of transition zone index, like I mentioned in the beginning. If the depends on the location it transit, so you will give a transition zone score. For example, in this case shown here, if that transit between V3 to V4, the sinus rhythm transition zone score is 3.5, and for the PVC is here, so it is 4.5. So PVC minus sinus rhythm, if you get a positive transition zone index, then it comes from the right side, like our case. And this slide shows you the V2 transition ratio. So like our case, it transit is quite late. So we will not count the transition zone transition ratio. But if that is early, we will count the transition ratio and see if that's less than 0.6, it is coming from the RBOT. If it is higher, then it's coming from the LVOT. So from our EKG, we will consider that coming from the RVOT. But here I also show you some parameter counting from this VPC. You can see the pseudo delta wave is 46 milliseconds, and also the QRS duration is 168 milliseconds, and also the MDI is 0.58. So if we look at those parameters, of course, it is somewhat you was consider quick, possibly coming from the epicardium. So here I propose an algorithm. This is an algorithm published in 2010 from Marchelinsky's group. You can see that here showing the EKG of our case, and we have 4 steps. If you finish 4 steps and it doesn't look like epicardial location, then we'll consider endocardially. So you can see that if there is any presence of inferior Q wave in the inferior lead, if that is no, we will go for the next step like our case. If pseudo delta is more than 75, we will consider epicardial. So because our pseudo delta is 40, between 40 to 50, so we'll go for the third step. And if MDI is more than 0.59, we'll consider epicardial, but ours is 0.58. So we will go for the last step, and we do not have the Q wave in the one. So we will consider that as an endocardial origin. So regarding the RVOT location, because we consider that as an RVOT PVC, so we will further look inside where is the location of this PVC within RVOT. So you can see according to this algorithm, our case is the bundle benchmark morphology and inferior axis, and we have a quite late transition. So if late transition, we will search in the RVOT. If early, of course, maybe it is coming from the right side, the left side, sorry. So it's late. So our QRS duration is more than 140, and you can also see notches of the inferior lead. So we will consider that maybe coming from the free wall part. Okay, so for this case, this is the ablation material we used for the procedure. We use Enzyme Precision 3D mapping system with the mapping catheter of HT grid. And also we use an ice catheter ViewFlex Extra. And for the ablation catheter, we use Teticus catheter. At the venous access, we prepare with the SL0 long sheath, as well as the 10 French short sheaths for the ice catheters, and use the Philips portable ultrasound system for the ice catheter. And you can see that in the beginning, usually in our lab, in the beginning, we will do an angiography of the RVOT, especially we will put the pigtail around the pulmonary valve. Why we have angiography around here? Because later I will show that some cases of the PVC in the RVOT actually is coming from the pulmonary artery or around the pulmonary cusp. So we would like to identify the location and anatomy of the pulmonary valve, and also either supravalvular or infravalvular area. And like this case, after injection of the contrast, you can clearly identify where the cusp is. And according to the publication in year 2015 from Ouyang's group, you can see shown here in this slide, and the panel D is the 3D or the reconstructed anatomy of the aorta and also the pulmonary artery as well as the pulmonary cusp. And you can see that usually in the IL view, the anterior cusp is most anterior, and the right cusp and left cusp is lower. So if showing on the fluoroscopy, it delineates the line, dotting line here, the anterior cusp is here, and lower part is the left cusp. And right cusp actually is a little bit higher, and maybe within the same level of anterior cusp. And from the AOL view, you can see that anterior cusp is here, and then right cusp, left cusp. So point to the fluoroscopy. Here is right cusp, and here is the left cusp. Usually left cusp is lower, and upper part is the anterior cusp. And also, I would like to ask you to focus on the catheter shape. You can see if we are going to map the lesion above the pulmonary cusp, better to use a reverse U curve for that. because if you use you directly put your catheter above the pulmonary valve, then it is sometimes have not having a good contact, so you cannot get a good signals. So this is how we map the lesions above the pulmonary cusp. And so this slide just show you an example that they do an ablation at the RVOT subvalvular area and fail. So they go above the valve and use a reverse U curve to identify the origin coming from the right pulmonary cusp. And from the fluoroscopy, of course, this view this is right cusp in the RAO and LAO. And also, I would like to ask you to focus on the surface EKG if that is coming from the right pulmonary cusp. Usually the lead one should be positive. And also you can see AVR and AVL. AVL is not very negative or even a little bit isoelectric. And 2, 3 AVF is not compared to the left cusp or anterior cusp. It is a little bit lower, shorter in amplitude. And this is the left cusp example. And you can see left cusp is here from the fluoroscopy. And also the surface EKG, you can see the lead one and AVL are negative. And of course, the inferior lead is higher in amplitude of the 2, 3 AVF. And similar morphology of the anterior cusp. And lead one is also negative, and inferior lead is also higher. So that's a characteristic of the origin, BBC origin coming from the three cusp. And of course, from the fluoroscopy, you can see should look like here if you put down the anterior cusp and also AOL view anterior cusp here. Lower part is the left cusp, and to the right side, right part, it is in the AOL, it is right cusp. Okay, so for our case in the beginning, we use the HT grid to make a geometry as well as the activation map coming from the PVC. But maybe it is somewhat difficult for you to see the signal because monitor is small. So maybe I would directly go to the next slide. And it is very important while you construct the map of the geometry of the RV and RVOT. If you see some heat signal during navigating your high density mapping catheter, I would recommend you to mark the right bundle and his location, because in some case, your focus may be close to the para-His area. So it's better to identify the His area during constructing the shell as well as the activation map or voltage map. So if you see this kind of signal, you will ask the rep uh, to make a mark on this area, then you will know where the AV node is, and his right bundle and his bundle is. And this this slide shows you the activation map we identify after collecting the VPC within the RV and RVOT. You can see the white color area located here, and this is the electron signal bipolar, a unipolar signal of this earliest activation site. And for the earliest activation site, you can see a unipolar QS pattern. And also for the bipolar signal, it is 47 milliseconds earlier compared to surface EKG QRS. And our surface EKG QRS showing the lead one is negative. And also the 2, 3 AVF is higher in amplitude as well as a negative polarity of the AVL. So it should be coming from either the anterior free wall, or if that is above the pulmonary cusp, it could be anterior cusp or left cusp. So according to this area, of course, it is somewhat you need to identify, you need to compare with the fluoroscopy that you take in the beginning for the angiography to see where that is. It is above or below the valve. Of course, in this case, we have ice catheter. So it is easier for us to identify what it is above or below the valve. And this is showing that using the HG grid, of course, we also can use other software, the live view. If you navigate your HG grid within the chamber, you can see during the sinus reason, the activation color and propagation color from the live view software or during the PVC is different. I think maybe I go through to the next one that when we put the HG grid to near the focus of the earliest activation site, you can see that during the science reason, uh, the this part of the grid will showing in purple color, but during PVC it will white out. You can see that that bit is PVC. So when you change the activation propagation direction, you will know where the earliest location is. And this is a live view for the earliest activation site. And of course, we also do the pace map for the earliest activation site, the pace map. And because for the HG grid to identify the early activation, if that is higher than the point valve, it is sometimes not easy to get a good signals. So if you feel the signals above the point valve is not good enough, maybe we need to use a single tip catheter ablation catheter to have a reverse U curve above the point cusp to identify a good better signal. So for this case, this is the pace mapping around the earliest activation site. You can see we can achieve a 94% higher correlation here. And it is a little bit leftward compared to our earliest activation site, but actually not very far away, just nearby. And sometimes we may see some case with the early activation and preferential conduction and breakthrough exit here. So it's sometimes it's just nearby the pace mapping site is nearby the early activation site because of the preferential conduction. And this slide just showing an example because we also try to go above the point cusp to make a good activation signals and also the path map. And we just put the slide and put the ablation catheter above the point cusp. And this is the reverse U curve for a right cusp mapping. And the next one is the reverse U curve for the left cusp mapping. Of course, we say that left cusp is lower, and here should be the anterior, and here should be the right. Then for the LL view, anterior is here, and left is here, and right should be here. Okay, so we identify the location, but actually we start ablation from the left cusp because the pace map, the highest pace map location is near the left cusp. So you can see that we ablate below the valve area, subvalvular area, and this is LT root. So that is left side cusp. But actually, after ablating that, is still some PVC noded. So we try to identify the another location near the subvalvular AC and RC side. And finally, we success ablation. We eliminate the PVC here. And this is the before ablating the AC-RC junction subvalvular area. And we do the pace map again to identify the higher correlation at this location and also give the energy later. And I think later we will apply the energy on this video. And this is just we doing the pace map for that. And also because using contact force catheter, and we try to push it about just subvalvular area. So sometimes the contact force is a little bit higher. But we try the energy around 25 watts for ablation because if we titrate up the energy, then the patient will complain of pain because she is relatively young. So after giving the energy, the PVC gradually disappear. Okay, so after the ablation, and we add the issue pure to see if there is any PVC coming from the other location or the original PVC. And also we observe for the 30 minutes. And you can see this slide, the left side is the original PVC and the right side is very limited PVC after adding issue pure. And this PVC morphology is different from the morphology we observed in the beginning. So that means this PVC is another location. However, it is very limited. Maybe I remember that we only see that maybe every 5 to 10 minutes, we can see one isolated PVC. So we just leave that alone and then observe and stop the procedure. So I think this is the end of my first case. And so maybe we can have a short discussion for our first case, or if any questions coming from the audience or moderators.
So, so Dr. Lowe, that's a great case, and I think it's a nice to really review the cusp anatomy because it's actually not very straightforward for all of us. Do you, when you deal, if you think your PVC is clearly in the RVOT, do you typically always just check above the valve just to be sure that definitely below the valve is good enough? Or if you find something that's really good below the valve, you're just gonna go and just not bother checking above the valve? Because it takes a little bit of time for some of us to hook the valve up and things like that.
Yes, thank you for your good questions. And why we recently routinely check the location around the valve, either subvalvular or supravalvular. Although the publication from Ouyang's group, they say around 10% of the patient having the PVC above the valve. But recently we found that maybe not that low and even a little bit higher incidence. And also even some patients just immediately below the valve, we call that subvalvular area. So at least we will check at the subvalvular area. But if you see your activation map is fairly clear, it is very low part of the RVOT or even near the caudal area, paralysis area, of course we will not go above. But if this is higher part and also you check your earliest activation site is really higher, but then above that it shows gray color without using the reverse U curve. That means that is above the valve. We will try to go up and use the reverse U to identify the signal above the valve. Of course, depends on the location. Like you mentioned, if low enough, of course, we will definitely not go up. But mostly most cases, because that is not low, so we will go up.
That's great. Yeah, I think I agree with you. It's funny how as things get described, it used to be very rare and then it becomes more frequent. Just like when we first started doing these ablations, we thought everything was RVOT.
Yeah.
And then now I think like more things are left-sided than they are right-sided. So it's always interesting. So there's some nice questions from the audience. One of the questions is for pace mapping, what percent correlation do you think is good enough?
Well, usually because of course we will try to get as high as possible, but at least maybe 95% or even higher would better. Because if that's between 90 to 95, of course we feel our experience is somewhat higher, or of course compared to that above the 95 is somewhat higher recurrence rate. And also sometimes maybe that is you are not at the exact location just nearby, because sometimes we use like I also see a first question, how much of the output. It also depends on the output. If you have a higher output, of course you may capture nearby neighboring tissue. So even you get a high percentage of pace match correlation, still may not easy to eliminate that. So if you use around 3 milliamp or to 5 milliamp as the capture and have a 95% higher, I would definitely go for ablation at this location.
Mm-hmm. And when you're dealing with another question is when you have to do the U-shaped curve, what kind of size curve do you use on the tacticath?
Well, usually I use medium curve, but it depends on, not because of we go up to the pomade trunk, it depends on the anatomy of the RVOT. So mostly we use a medium curve, not large curve. Of course, if a younger patient, they have a small chamber, especially in Asian population. So using larger curve somewhat difficult for you to make a reverse U above the trunk.
Yeah. And we have a couple more questions. One is, I assume that's a coronary angiogram. Do you do a coronary angiogram when you're ablating the RVOT? Do you worry about coronary artery injury, especially if you go above the valve? I think there is the vessels are quite close.
Yeah. Yes. Yes. So, yeah, sometimes we will do a coronary angiogram because, like you mentioned, right, the anterior septal part of the RVOT is close to the LAD, and posterior septal part maybe to the right side. Yeah, so yeah, somewhat for this case, we did not do the coronary angiogram. Of course, it is a good idea. Like it's safer to have a coronary angiogram before the procedure.
Yeah, yeah. And then I think one last question here is, how long do you wait before you declare victory?
Well, usually for every case, at least we wait for 30 minutes at least. And
Mhm.
if the patient have a large burden in the beginning and we are confident that it disappear immediately after our first stable shot, we will wait only 30 minutes, of course, including the provocation test with a medication, for example, isopropyl, atropine, or adenosine sometimes. But if the patient have a very limited, at least we'll wait until 1 hour before we stop the procedure. Yeah, how about
Yeah,
you?
I think, yeah, my rule, that's exactly right. It's the waiting period is inversely proportional to amount of PVCs they walk in with. So the more they have, then the shorter your procedure overall. The fewer they have, the longer the procedure. Even after you do ablation, I totally agree. 60 minutes is pretty good. The tough part is when you see one PVC
Yeah.
during the waiting period, and it's a little annoying. But it also underscores how important it is that you have to, if you're going to go on, you got to make sure it's the best possible site. And I completely agree. If you're going to take the extra time to map above the valve, even if it looks good below the valve, just check, because the thing you don't want to do is to suppress it, and then you pull the sheaths and then you see a PVC on the screen.
Yep. Yeah. Yeah, but
And
sometimes the patient having PVC after back to work, so it is somewhat trouble.
we've all been there. That's great. And I think there's one more. Do you use the lesion size, the LSI, when you do PVC ablation?
For the PVC, we usually use LSI in atrial arrhythmia ablation, but for the PVC, I need to say that we seldom use a lesion index to look for the effect of the PVC. We see how it disappear, and also observation period. Actually, currently we do not routinely use a lesion index to for the PVC ablation.
I agree. You look for effect, impedance drop, and sometimes especially and some parts of the the anterior RVOT is quite thin. So the thing you don't want to do is you already have a good effect, and then you're chasing the lesion index, and then you cause a steam pop, because you're really wedged in. That can be problematic.
Yeah, because sometimes we also use a little bit higher energy, 35 or even higher. But if you look at the lesion index, I don't know. Yeah, because if there is a pop there, it is very terrible.
Yeah. Good. I think that's great. I think we're good with the questions for now. And obviously, as more questions come up, we can move on to after the second case.
Okay, thank you. So Dr. Lo, can you proceed to a second part of the case? Thank you.
Okay, sure. Let me share that. Okay. Okay. For the second case, the history of this case, he is a 41-year-old gentleman, and actually this time is the third ablation procedure. And he received 2 ablation procedure before. The first time is last year in 2019, December 2019. And we identified a right point cusp PVC and successful ablation at that time. But after home, the patient got relapsed and showing some PVC, and because of increasing burden, so he received a second procedure in this March. And unfortunately, it is hard for us to apply this PVC. And we apply the both because of changing morphology, I will show later. We apply left point cusp and anterior point cusp, and also either supravalvular and subvalvular, or even go to a right coronary cusp, and still fail to ablation. So the Holter monitor in this July also showing the 11% burden of the PVC. And it looks fairly idiopathic. Cardiac MR is negative for this case with fairly good ejection fraction. And you can see that during the first ablation procedure, that we identify the PVC after adding the medication, because when patient enter the EP lab, It is fairly limited PVC. I think some cases have this kind of behavior. You can have lots of PVC at home, but when you enter the EP lab, because of changes autonomic tone, so a patient is anxious, so only limited PVC found. And it is 45 milliseconds earlier than the surface EKG and good pace mapping location in the subvalvular pulmonary cuspid region. So you can see this is glass view for the location of the highest pace map area, and this is the surface EKG of the PVC. And you can see the transition area is the V3, and the V2 transition ratio is 0.58. That means it could keep coming from the right side. And the pseudo delta and MDI is showing here, and AVL-AVR ratio is 0.6. And also you can see the inferior lead. The inferior lead is having some notches, and also the lead one is positive. So also the AVL is negative, but not less negative. So that's why we get a successful site near the right coronary cusp. As I mentioned in the last case, if the right coronary cusp or either supra or infravalvular area, you will get this kind of morphology. So this is also another view of the earliest pace mapping location, a 98% correlation of this PVC. And this is just another view of our ablation lesion tech here. And this is a right subvalvular right coronary cusp, because you can see this is the contrast field in the pulmonary valve. This is the LL view, IO view, and this is right cusp, left cusp, and also this is anterior cusp and right cusp here. So this is a right cusp area, subvalvular area of that PVC. So unfortunately, the patient got relapsed after that. So in the second procedure, the PVC morphology is showing here. I would like to run in the PVC morphology and let you see. And you can see in this time, the lead one and the AVL are more negative. And lead one from positive in the first procedure and become negative now. And also the lead 2, 3 AVF is even higher in amplitude compared to the first procedure. So that means maybe it moved to even the leftward position. And for the other parameter, you can see that the MDI is not higher. It is 0.51, and the pseudo delta wave is 20 milliseconds. And another is a V2S V3R ratio. It is 4.12. And if this ratio is higher, that means it coming from the right side. If that is lower, less than 1.5, it could be coming from the left side. So for this case, we still consider it could be possibly coming from the right side. So we do the activation map, and you can see that it is 36 milliseconds earlier in the left pulmonary cusp supravalvular region. And this slide shows you the V2S V3R index. And if you can get a higher index, that means it is coming from the RVOT. If lower, so for our case in the second procedure, it is 4.6. So it is coming from the right side. So actually, we did lots of ablation, either above or below the valve of left pulmonary cusp. So you can see I provide some data here. Is subvalvular is even earlier, and supravalvular is -30, but we fail to eliminate this PVC. Only transiently suppress the PVC. So we also go for the right side to target this PVC. However, still fail. And because the long procedural time, we terminate the procedure at that time. Unfortunately, the patient got relapse. Maybe I cannot say relapse. I should not say relapse because we did not totally eliminate that. So the Holter monitoring this journal showing that still 11% of the PVC. And this is a surface EKG, but I think this one doesn't capture the 12 lead, only limited lead. So when patient re-enter the EP lab this July, before ablation, again, there are very limited PVC. And for this case, very interesting, although I did not provide any figure of that, but during the procedure, when we pace the coronary sinus, actually the PVC will disappear, will appear, will show up. But without pacing, just during sinus reason, there was no PVC. And this is a PVC after pacing at the coronary sinus length, also after issue infusion. And you can see the PVC morphology, still the L1 is negative. And AVL are also negative. And you can see that obviously our V1, V2 this time have a higher R wave in R wave amplitude. This is RF morphology in the V1. Of course, it takes a concern. Could it be possibly coming from the LVOT or either other location between the RVOT, LVOT, or summit area? And you can see the V2 transition ratio is 0.56, just a border, also borderline maybe indicate the right side, but still R wave here that make our also give us a concern. And V2S V3R ratio is at the border this time, not like last time, is 4.6. This time is 1.6 only. So this time we decided to go both RVOT and LVOT as well as GCV, AIV to identify the location. And talking before I go to the mapping result, I would like to show you the anatomy of the LV summit area. A summit area usually is this triangle between the LAD and circumflex artery, the first branch in here. And this is the aortic root. And actually the RVOT is cut down here. But you can see if RVOT is appear in this anatomy should be here, and aorta is here, RVOT is anterior. So the between the middle part between the aorta and RVOT and this area, especially this area is the highest part of left ventricle, we call that as a summit area. If the patient's PVC is coming from here, it is somewhat difficult to ablate, give energy. And for this area, because we also have a coronary sinus system, and this blue part, it is a great cardiac vein. It is along with the circumflex artery, so great cardiac vein is here and to the AIV here. So sometimes you can approach this area through the great cardiac vein or AIV. Of course, usually we will try to ablate this area from RVOT, septal area, or in the aortic root cusp area or subvalve area. If fail, maybe we will try to get inside to a GCV or even AIV, or if still fail, we may consider to do an epicardial approach for that. Because this area is a triangle area between these three anatomical structure. So before we have published a paper using the QAVL AVR ratio, try to identify that the successful side of the summit BPC. You can see that if this ratio is lower, you can apply that from the coronary cusp or even RVOT septal area. But if that is getting higher, you may need to go to the subvalvular of the left side, or even higher between the 1.5 to 1.74, you need to go to the GCV AIV for ablation. If that is even higher, more than 1.74, that means you have a very deep AVL Q wave. Then you need to go to epicardial location to ablate this PVC. So for our case, you can see that in this time, we use a two decapolar catheter. One is placed in the RVOT, another is placed deeply inside the coronary sinus to the GCV and the ostium of AIV, in the IL view and LL view shown here. And for the tracing here, the deca signal is coming from the RVOT, and the CS signal is coming from the decapolar catheter within the GCV and AIV. And we also put another catheter in the aortic root in the RCC area. And we put a single tip catheter showing in the RBA tip here, signal here. It represents the RB catheter this catheter in the aorta. And you can see during PVC, we can get a very, very early signal coming from the GCV AIV area. And it is CS12, that means it's coming from the DECA 1, 2 here. And from the signal in the RVOT posterior septum, And you can see that it is a little bit later compared to the decapacitor in the GCV AIV. So maybe the case is coming from here because we also can see the ratio. Sorry, maybe I would need to go back to the previous slide. We have count the QAVL AVR ratio and showing here, and it is 1.61 this time. So according to the algorithm showing on this slide, you can see if that is 1.61. Of course, it's compatible with the location within the GCV AIV. So in this case, we decide go into the GCV for operation. And we also construct the activation map for this case. And you can see that this shell is the GCV AIV shell, and this one is the RBOT posterior septum. And you can see the earliest location is locating here from the lateral view, and also here from the right lateral view. So it is within the GCV AIV. Okay. So we put the ablation catheter within the GCV AIV and showing the also very early, 15 milliseconds earlier, and some pre-potential or fractionated potential in the beginning. And you can see that why we paste from the CS, because it is very interesting for this case. When we do the CS pasting, the PVC will show up, but without pasting, only very limited PVC. I don't know whether that is because of the calcium load within the cell or not, but it is very interesting case because when we paste the CS, we are not intently to get the PVC, but the PVC come appear during pasting from CS. So we keep consistently pasting from the CS to get the PVC. So we can see the ablation signal during the PVC also show again here is very early. So this is the unipolar signal of the earliest location of that within GCV and ARV. We can also see a QS pattern, but actually, in fact, I need to say that this QS is not very sharp. It is only blunted with some fractionation here. So of course, it could be coming. We are very near the true location, but maybe just a little distant from the true location, but it's within the GCV AIV. So the pacemaker correlation are showing on this slide. And we do the 2D pacemaker from the bar system, and you can see the 99% correlation of this PVC pacing from the GCV AIV. Okay, because within this area, as I mentioned in the summit area, it is close to the LAD and circumflex. So for the cases of the PVC coming from the summit, usually we will routinely do an angiography before giving the energy. And you can see the coronary angiogram showing here. And this is the ablation catheter within the coronary GCV. And this is the IO and LAO view. And you can see, although from LA view, it looks we are touching on the anterior descending artery. However, in the IO view, there are some distance between that. So we measure the distance to the circumflex as well as the LAD. And it's around 4.3 millimeter to the LAD and 6.7 millimeter to the circumflex. So we decide to give the energy here. So you can see that this also another figure showing the pace map of the earliest pace map and activation map. It is quite at a similar location. So in this case, this is an ablation. Before we give the energy, there are some PVC. And after giving the energy, even pacing from the coronary sinus, we do not have any PVC at all. So for this case, our final lesion site is located at the GCV and AIV. GCV and AIV. So this is the post-ablation coronary angiography. You can see after ablation, the coronary angiography looks similar compared to before ablation. So there is no disappearance or any coronary vessels, especially the main branch. Of course, we do the equipment infusion in the end, also pacing from the coronary sinus, and there were no more PVC. And the patient received the ablation in this July, and actually, he received a Holter monitoring early this October, maybe 2 weeks later. And there is zero PVC on that hotel monitoring. So we are confident that this time we definitely eliminate this location. So our diagnosis is the LV summit PVC post successful ablation within the GCV and AIV. After 15 minutes of operation, and we observe the EKG still no PVC. So we terminate the procedure. And thank you very much. That's the end of my second case presentation.
Great. Well, that's a great case. I think it's almost like for AF ablation, it's like stepwise approach. You have to PVI, then lines and lines. And I think I feel like you actually had to do, I really am convinced that you had to do all those different spots to eventually get it. I think you just kept chasing the exit and then you finally got it. And, two points before we go to the other questions by the panel, by the attendees. One point is about the coronary sinus. I've seen the exact same thing where the CS pacing will induce the PVC. And what's fascinating is I think it's due to the increased intracellular calcium, but what's interesting is when you burst pace from the ventricle, oftentimes I won't see it. It's only if you do atrial pacing with intact, hyperkin. I don't know, it's maybe a synchrony issue or there's something about not just the rate, but the actual way the ventricle is being activated that somehow it causes the PVCs. And maybe we could put it together and write it up. I don't know why that's the case. And when you're ablating in that area, how do you start your power? And oh yes, that was actually good because someone else actually asked the same question. How do you start your power? How do you deal with high impedance issues?
Yeah, it is a good question. How we use the energy within the coronary sinus. It depends on how distal you ablate because for this case, luckily we are not very distal in the AIV. So when we start the power energy, usually I will start from 20 to 25 watts. And usually if 25 to 30, maybe the either energy or impedance will change and the generator will automatically stop. And so we start from the 20 to 25 watts. If it is not very distally, of course we will keep the irrigation on, because if that is very distally within the ARV, the branch of the vessel is very small. So it will it will let the water not irrigated from the distal hole. So the generator and also the system will alarm and also stop the energy application. So if that is really in this situation, we will change to a temperature control mode, not the power control mode with irrigation. But if we can use the irrigation, of course, I will try to use 20 to 25 watts in the beginning. For this case, we success at 25 watts. And of course, impedance sometimes will be very high. So actually, we will change the setting of impedance to the highest, but sometimes still the system will block after energy for several seconds. So it is somewhat because we cannot turn off this impedance limit from a generator.
Yeah, we run into similar issues. And there's another question about, this is more of an ECG question. Explain a little bit more about lead one, sort of, and and I think this is a good discussion. When you're dealing with lead one, how do you deal with the positive, negative in terms of anatomy? How do you correlate that? How do you interpret that?
Yeah, usually lead one and AVO are left lateral side lead. So if your focus is coming from this location, of course your lead one will be negative. For example, if talking about RVOT, if you see lead one is negative, then you will consider that it is close to the anterior septal side of the RVOT. Sometimes when the RVO, it is at the pulmonary artery because the RVOT goes up to the pulmonary artery and go to the more leftward side. So if that is within the pulmonary artery, also the lead one and AVO would be more negative. And if that is positive, of course, it is not very left side. So it could come in from the mid to postural septal of the postural septal free wall of the RVOT. But because this audience also raised, it can differentiate free wall or septal wall. Usually we differentiate the free wall septal wall using several criteria. For example, if your QRS is wider than 140 milliseconds, or you can see a notches of the inferior leads. Also, if you can see that it is late transition, later than V3, V4, we will consider that as a free wall location compared to the septal. Septal will have narrower QRS and also no notches and sometimes very early transition because posterior septal area is close to, I should say that septal area is close to the anterior wall of the left ventricle outflow-tract. So in the septal area, we look at those factors instead of the one only.
Yeah, I think, with ECGs, because if you look at histology, if you look at the RVOT, the back wall of the RVOT is right up against the aorta. We know that when you look in ICE, you'll see the right-left commissure when you open up the junction of the RVOT and the pulmonic valve. It's right up at an angle with the right-left commissure. So I think it's important for the audience to know that it's important to kind of think about these ECG patterns. But remember, these spaces are so close to each other, and frankly, where you get your successful site depends on which place you go first. And I think that some of these areas you could have started on the left side and then moved the exit out to the right eventually, and then right back to the left. So always keep an open mind is sort of my approach. Use it as a guide, but I've written papers on this, but we all know it's derivation cohort versus validation cohort. It always doesn't perform as well when you try to validate it again. So always keep an open mind. Great. So one question here is, how often do you see the PVC only during ISO washout, but not while you're giving the ISO?
Yeah, I need to admit that it is quite often during ISO washout. I think it's a concept of autonomic manipulation, and during aiding the issue period, we try to simulate that it's a sympathetic activation, but during ISO washout, it is withdrawal of sympathetic. However, withdrawal of sympathetic doesn't mean increase of vagal, so it is somewhat different situation, but we do not have any method to try to increase the vagal tone and see if possibly BPC comes out. But for lots of PVC, actually the patient have some diurnal pattern and happen at night or during resting or after a meal. So for those cases, if you add issue pill, of course, you will not see anything. And even after the heart rate accelerate, and you still see nothing happen. So although issue per washout phase, it means a sympathetic withdrawal, but sometimes some vagal activate related PVC will appear at this moment. It also a similar situation that we will put the patient on treadmill. And after at the recovery stage or after treadmill, you can see lots of PVC, but when exercising, no PVC at all. So I don't have an exact percentage how many percentage of patient having the PVC at that time, but it's usually I will watch these periods because lots of PVC develop during the issue period washout.
Yeah, I agree. One more question. What is your PVC burden cutoff where you're gonna say, okay, I'm gonna go for ablation, or maybe not, just try medications first? Is there a number that you kind of think of?
Yeah, it's a good question because we know that while we apply PVC, there are two consideration. One is symptom, and other is you know that as PVC goes higher burden, then it's possible to have a PVC induced cardiomyopathy and decrease in the ejection fraction. So based on these two consideration, we do the ablation. But how high we do that? Usually in our lab, if that more than 5 to 10%, we will do the ablation if patient also symptomatic and refractory to medication. If no symptoms, maybe I will tolerate and keep the higher higher burden to 20 to 25% because from the literature, above 20 to 25% is higher possible to get the cardiomyopathy later. But if symptoms, I will lower down my threshold to around 10% of the PVC burden. So after ablation, if the patient having some PVC but lower burden, I will keep the medical control unless the patient is very symptomatic and refractory to medication again. Because you know that some of the cases really come here for very low burden but very symptomatic. For example, yesterday I have a case, only 400 PVC, but very symptomatic and cannot tolerate even one PVC. And unfortunately, we put on the table and no PVC at all, and wait for 2 hours, no PVC, no one PVC, so we stop the procedure. But after back to word and PVC again. So if that is too low burden, it is difficult for the operator to catch that during the procedure, or no endpoint for the operation.
Totally agree.
So I think short comment. I think this if your physician think if the patient is a little bit risky for the cardiomyopathy or the malignant arrhythmia, I think it is worse to do the procedure. So not usually we set up the criteria to be 10 or 50%, but however, we may have some assessment for the patient. If a patient have a structural relative underlying structural heart or cardiomyopathy, maybe the cutoff threshold could be even lower, maybe not purely structural normal heart. And second, if a patient may have a syncope history, maybe we may consider the underlying could be, sometimes the BBC could be malignant, proceed to the VT or VF. So we may consider to have the procedure with a lower threshold for the BBC burden. Yeah, this is my short comment.
Yeah, totally agree with you. Yeah, if we see a VTAC and also some possibility of malignant transformation, of course, even very limited, we will try our effort to do the ablation.
Okay, so thank you. So I think the time is up. So any comment from Professor Jun Chong? No.
No, these are great cases, and it's a great discussion. I mean, it hits a lot of great points.
Okay, thank you very much. I think time is up. So today I really appreciate Professor Chun Jong and also Professor Lo Li Wei to provide the two cases. The first case is a typical RVOD, but the origin was coming from the pulmonary trunk cusp area. And second case, a repeat procedure case, coming from the submit region, and final susceptible site was in the coronal sinus. I think this provides a very important step-by-step approach for the Outflow-Tract VPC. Thank you very much. And this come to the end of today's session. So then we are expecting 2 weeks later, we have section 2, the step-by-step approach for the scar related VT as shown here, and the session will be given on the 7th November. So I hope all the audience can come to the section and 2 weeks later. Thank you. And Professor Lo, Professor Chong, thank you very much for your talk today.